This is a real blind spot in medicine. A lot of the medications that people take every single day were never actually designed to be taken every day for a long time. The trials that got them approved ran for weeks and maybe several months, and in rare cases, a few years, but not decades. And somewhere between that initial prescription and the automatic refills, that timeline got lost. And for a lot of people, what started out as a temporary solution has now turned into a long-term risk. And when I say risk, I mean real, documented clinical risk. So we're talking about kidney damage and memory loss and increased risk of dementia. And then there's falls and fractures and even physical dependence. So if you're taking something for heartburn or for sleep or anxiety or nerve pain, check your medicine cabinet right after this video because there's a good chance something in there falls into this category. And the problem isn't that you're taking these medications. The problem is that nobody has stopped to ask whether you still need it. So in this video, we'll go over what these medications are, and I also want to go over good and natural alternatives to consider that do not require any pills at all. And this is important. Even though I'm a physician, I'm not your physician. So please talk to your doctor before making any changes to your medication regimen, as this video is educational only and not medical advice. So let's start with one of the most commonly taken drug classes in the world, and that is proton pump inhibitors, or PPIs. So these are medications like omeprazole, sold as Prilosec, or esomeprazole, which is Nexium. Another common one is pantoprazole, or Protonix, and there are many others, and most people take them for acid reflux or heartburn. And in the short term, they may work well. The problem is, for many people, that short term stopped meaning short term a long time ago. So now I want to go over why I actually rarely recommend these drugs to begin with. So the way these drugs work, your stomach produces acid using tiny pumps in the cells that line the stomach wall. So PPIs block those pumps directly. They're proton pump inhibitors. So your stomach produces less acid, which then may improve the burning sensation or the discomfort with heartburn. Simple. And for some specific conditions like active stomach ulcers or an H. pylori infection, these drugs are absolutely necessary. But here's the thing, these drugs do not fix the underlying issue. And the way I think about it is, it's like pulling the battery out of your smoke alarm. The smoke is still there and the fire is still there. You just stop hearing about it. And the real problem, whether it's a weak valve at the bottom of your esophagus, or in some cases it's actually too little acid produced, which then affects digestion, or it could be excess pressure pushing on the stomach, none of those things go away. The only difference is you've silenced the warning signal. And here's what I want to emphasize. The downstream problems from long-term acid suppression are very real. And first is kidney damage. So the 2025 Veterans Affairs Guideline analyzed the FDA Adverse Event Reporting System data from 2019 to 2023, and they found that 7 out of the top 10 drugs suspected of causing serious kidney injury were PPIs, which represents 86% of those top 10 cases. Long-term PPI use is also linked to important micronutrient deficiencies. So the big one is magnesium. You need stomach acid to absorb magnesium from food. And if you block acid production long enough, well then your magnesium stores may suffer. But it's not just magnesium. PPIs can also lead to a vitamin B12 deficiency. Just like with magnesium, you need stomach acid to release B12 from food proteins that we ingest. And studies show that using PPIs for 2 or more years is associated with a 65% increased odds of a B12 deficiency. Now, these numbers are all based on observational data, so they show a link, but it does not prove causation. But mechanistically, it does make sense, and we have to pay attention because magnesium is involved in over 300 processes in the body, including heart rhythm regulation and bone health. And low B12 can also cause irreparable nerve damage and cognitive decline. So if you've been on chronic PPIs for months or years for something like heartburn, definitely check in with your doctor to see if there's any kind of alternatives. With heartburn or gastroesophageal reflux disease or GERD, the number one goal is to fix the underlying root cause. And once you do that, the symptoms will take care of themselves. And you've probably already heard the basics, like raising the head of your bed, or figuring out which foods trigger heartburn. But both of those things can be hit or miss. So the way I approach this with my patients and myself when I have issues with heartburn is we focus on 3 things. And if you do these 3 things, there's a very good chance your heartburn will go away naturally. So if you visualize the anatomy of the stomach, we approach this from 3 different angles. First, we lower the pressure around the stomach, because if there's too much pressure, it will push the stomach acid into the esophagus. And second, we try to tighten the sphincter, or the valve that prevents stomach acid getting into the esophagus. And then the third step is we try to increase gastric emptying, which is how fast your stomach moves food into your small intestine. So let's tackle the first step, reducing the pressure around the stomach. And this is usually caused by excess weight. And for most people, weight loss will help quite a bit with heartburn. But this is where I like to get a little bit more specific and more granular. It's not just any kind of weight loss that's going to help. It's the weight loss around the midsection, especially if you have excess visceral fat. Because visceral fat increases the pressure under your diaphragm and pushes stomach acid upward. And here's why this is so important. So there's studies like this one that looked at CT scans and found that reducing visceral fat improved reflux esophagitis by more than 3-fold. But similar changes in the subcutaneous fat did not show the same effect. And I made a couple of videos to go a little deeper on all the different ways to reduce visceral fat that you can check out over here. Now, the second lever we pull is we try to tighten that lower esophageal sphincter that is so important in preventing stomach acid going up into your esophagus. And the best way to fix it is by practicing diaphragmatic breathing. Or another name for that is belly breathing. So when you take a deep breath, you want to feel that expansion in the belly and in the lower back as opposed to your lungs. So this basically trains your diaphragm, that large dome-shaped muscle under your lungs, to where the part around your esophagus gets stronger, and it will help keep the stomach acid and all of its contents from moving upward. It does take at least a month of daily exercises before you see the results. But for many people, that is the root cause of the problem. And once you fix it, the problem will go away. And then the third part is that gastric emptying, or helping the food move faster from your stomach to the small intestine. And the best thing for that is just taking a short walk after meals. And then on top of that, another thing that can help is drinking ginger tea after meals, because that can also help with digestion and expediting the gastric emptying. Now let's move on to the next section, which is the prescription sleep medications, and specifically the class called Z drugs. So this would be drugs like Ambien, another name for that is Zolpidem. And then there's a few other drugs that start with the letter Z. So it'd be drugs like Lunesta or Sonata. So these are sedative hypnotic medications, meaning they sedate the brain and they induce sleep. And these medications can help you fall asleep faster, but most of these drugs are only approved for short-term use, only a few weeks to a few months. In fact, the American Academy of Family Physicians discourages using any sleep medications for longer than 3 months. And the American Academy of Sleep Medicine recommends reassessing the use of these medications at least every 6 months. But I see so many patients who've been on these medications for years without any kind of reassessment. And this is where problems start. So when you take a medication like Ambien, these drugs act on the GABA system, which is the brain's main calming chemical. It's essentially the nervous system's brakes. So the drug pushes the brakes for you, and the brain slows down, and you fall asleep. But over time, the brain notices that it's getting this external outside help, and it pulls some of these GABA receptors from the cell surface. So the end result is the whole system becomes less sensitive to your own natural braking signal. And at this point, you need the drug just to get back to baseline. And that is dependence. And it can develop in just a matter of weeks. And with Ambien, the risk goes even further. The FDA has a black box warning, which is the strongest safety label they could put on the drug, specifically for complex sleep behaviors. So some people that have taken Ambien have been documented to sleepwalk or cook and even drive while asleep with no memory of it in the morning. And this is actually the main reason I personally never recommend medications like Ambien. So if you rely on these medications to fall asleep, I would definitely encourage you to talk to your doctor about alternatives. And if you haven't already, I would really hone in on the fundamentals because they matter much more than most people give them credit for. So what I mean by fundamentals is we want consistent sleep and wake times. This will anchor your circadian rhythm, which is your body's internal 24-hour clock. And then it's really important to get morning light exposure within the first 30 minutes of waking up. That sunlight in the morning is one of the strongest signals that will help you fall asleep naturally later that night. And if you were taking medication, a lot of people choose melatonin because it seems to be a more natural solution. But check out this video I made earlier on why I actually stopped recommending melatonin, and then we go over what other things you can do to fix your sleep without relying on pills. Now, the next category catches a lot of people off guard because you may be taking one of these medications right now and have no idea if it falls into this group. So this would be anticholinergic medications, and these are medications that show up under many different names. The most common one used is diphenhydramine, which is the active ingredient in Benadryl. And you find it in most over-the-counter sleep aids like ZzzQuil or Unisum or Tylenol PM. And then a lot of the overactive bladder medications like oxybutynin or tilteridine are also anticholinergic. And then older antidepressant medications in the tricyclic category like amitriptyline and doxepin also fall into that anticholinergic category. And here's what the research shows. So there was a systematic review and meta-analysis that pulled data from over 1.5 million people. And they found that anticholinergic drug use is an independent risk factor for all-cause dementia and Alzheimer's disease. And the risk followed a dose-response pattern, meaning the more anticholinergic exposure a person had, the higher the dementia risk. And then there was a separate meta-analysis that looked at 21 studies, and they found that anticholinergic drug use for 3 months or more was associated with a 46% increased risk of dementia. These studies show a link, but they don't necessarily prove that medications themselves cause dementia. And the real question researchers are still trying to untangle is direction. Is the medication itself pushing the brain towards cognitive problems? Or is it the people that take these drugs, they have insomnia or bladder issues, so they're more likely to have disrupted sleep, and it's the poor sleep itself that causes problems with memory and cognition over time. So the causation question is very valid, but I still take it seriously because there's just way too much data that shows this trend. And the data may be imperfect or incomplete, but so many of those studies show the higher the exposure, the higher the risk of developing dementia. So why risk it? And if you take Benadryl for allergies, talk to your doctor about switching to a second-generation antihistamine like cetirizine or loratadine or fexofenadine. And there's many other options because these second-generation antihistamine drugs are specifically designed to have less effect on the brain. So they may be a safer option if you need to take something long-term. And if you're taking overactive bladder medications like oxybutynin or tilteridine, talk to your doctor about alternatives. There are non-anticholinergic options. And it's also amazing how far you can get just with the fundamentals of bladder training and pelvic floor muscle training. There's randomized trials that show that these techniques show a 60 to 80% reduction in incontinence episodes in women. Okay, next up is a drug called Gabapentin or Neurontin. So this drug was originally approved as an anti-seizure medication, and then it was later approved for nerve pain after shingles. But now it's mostly prescribed off-label for things like diabetic neuropathy, or fibromyalgia, or restless leg syndrome, or anxiety. So that's a very wide net for a drug that was only studied for a much narrower indication. And the same pattern that we've talked about appears here as well. Most clinical trials evaluated gabapentin for only 4 to 12 weeks, and there's very limited long-term data beyond that. Yet, so many people stay on this medication for years without any kind of reassessment, and this is why it's such a problem. So gabapentin works by reducing the activity of excitatory neurons. They essentially turn down the electrical noise in the nervous system. So that's useful for certain types of nerve pain. But that same dampening effect over time can show up as cognitive slowing and memory problems and dizziness and impaired balance, which all of those things can lead to more falls, especially in older folks. And on top of that, gabapentin also carries physical dependence potential. So if you and your doctor decide to come off gabapentin, which if you're on gabapentin, that's a conversation that everybody needs to have, it needs to be gradually tapered off to avoid withdrawal symptoms. Now, I want to emphasize, I'm only talking about long-term gabapentin use for diabetic neuropathy. If you need gabapentin for seizures, or if it's the only option for severe anxiety, well, that's a different situation. But for many other conditions, you rarely need this long term. And the real question is whether the underlying condition is actually being treated. For something like diabetic neuropathy, well, the root cause is uncontrolled blood sugar. So better blood sugar control and improving insulin resistance with food and movement and exercise and reducing vitamin deficiencies, well, all those things will reduce nerve damage and nerve pain much better than what gabapentin can do, which just covers up the problem. Now, one category of medications I've not covered is antidepressants, because it's a much bigger topic and it warrants its own dedicated video to unpack everything. So stay tuned for that in the future. I hope this was helpful. Stay healthy, and I'll see you in the next one.